Alright, this video we're going to look at kind of conditions of the reproductive tract. So first, birth control. First is condoms. Covers the penis during intercourse and prevents sperm from reaching the female reproductive tract. And this is the only one that's going to protect against STIs, sexually transmitted diseases or infections, like syphilis, gonorrhea, human papillomavirus, which is HPV, and AIDS. Another form of birth control is for females. So this is changing kind of the levels of hormone. So this is estrogen and progesterone levels. And it's a very effective way of birth control because it's going to change ovulation. It has to be prescribed and you can't get it over the counter because it can cause issues if a female has hypertension, diabetes mellitus, epilepsy, meaning seizures that we don't kind of know the cause, gallbladder disease, heart trouble. You can either cause acne too. And there's an increase of venous thrombosis, which is going to be blocking of veins with clots, pulmonary embolism, so blocking pulmonary vasculature in the lungs with clots as well, or pieces, and heart disease. And especially women over 35, it's even more risky. We also have, so this is birth control with estrogen and progesterone levels. That's why you kind of take day one, day two, and they tell you which pill to take on each day. So it kind of changes and affects your estrogen and progesterone levels. So you can change your LH and FSH levels and ovulation as well. There are progesterone only birth controls. So that can be pills. You can also have Depo Provera injections, which is every 3 months. Sometimes uterine cycles in this and Depo-Provera can be regular or even stop in about half. A lot of times there's steroid involved, so you can have weight gain, and it can also, once stopping the injections, can have a slow return. So you stop them and it can take a while. If a female wants to get pregnant, it can take a while after stopping the injections. There's also interuterine devices, which are IUDs. They're either a loop or a T. So you can see kind of T, it kind of hooks into the uterus. And so that's put right into the uterine cavity. It sits there. There are two kind of major types that you hear of. There's copper type, which is actually going to stop sperm from moving really well. And so if sperm cannot get up to the uterine tubes through the uterine cavity, then it's not going to cause fertilization can occur. So copper is affecting sperm movement. Hormonal type is going to prevent ovulation as if you're taking the birth control pills. It can also, remember, we have a decrease in cervical mucus thickness. Um, this can actually thicken it even more, which stops sperm from entering too because they get stuck in the mucus. Sometimes another birth control strategy is rhythm, so kind of trying to figure out when ovulation is going to occur. So you can avoid intercourse when ovulation can occur. So you can look at body temperature, um, cervical mucus texture, a lot of times looking for the LH surge. This can be kind of a little more risky, about 13 to 20%. Trying this are still going to get pregnant because a woman's cycle is not the same. Um, and there's can be subtle changes that can potentially show that it's ovulation when it hasn't happened yet. We also have hormonal after intercourse contraceptives, Plan B. So we hear the morning after pill. That is going to be take up to 3 days after unprotected intercourse, and that's going to stop the ovary from releasing an oocyte um, for longer than usual. So, or it's going to stop fertilization. So basically, what happens is sperm can last in the uterine cavity for about 5 days, maybe longer. So if it's before ovulation, then it can stop ovulation from happening, or it can stop fertilization. And this is an over-the-counter medication. Another birth control is vasectomy. Each of the ductus deferens from each testicle is either blocked with a plug, or it's cut and tied off. If there's just a plug, then it can be easily reversed because you just take out the plug. If it's cut and tied off, then it's a little more difficult. It's a pretty easy procedure. Failure rate is pretty low. Still have normal testosterone and sexual function. Sperm are still produced, but they just are broken down and resorbed by the body. So they just can't go through the ductus deferens to the urethra. So just looking at ductus deferens cut and both sides are tied, so there's no connection. So sperm can be produced in the testes, but they can't travel all the way to the urethra to be released. You can also have tubes tied, if you heard that. Tubal ligation, same thing that you see in the ductus deferens, but in the uterine tubes. You cut and you tie both sides. So oocytes can be ovulated, secondary oocytes, but they can't travel. This is a little more involved procedure because these are internal. And so has to be done under general anesthesia. And you can do it with a scope. So scope into the abdomen and cut that way. And you have more complications because general anesthesia and you're going into the abdominal cavity. But it's pretty successful. And a lot of times tubal ligation, if a female is getting a C-section, they'll ask for tubal ligation at the same time because you're already opened up. Some disorders of the prostate, we have benign prostatic hypertrophy, so BPH this is a big prostate, enlarged, but it's not because of prostate cancer, it's benign. This can happen randomly over the age of 50 in males. This can be, there's a little less testosterone after 50, and more estrogen can actually potentially stimulate growth of the prostate, so getting it larger. A major factor of this and why we worry about it is, again, the prostate is surrounding the urethra. So if this is enlarging and getting bigger than normal, then it's going to cause pressure on the urethra. So urine can't pass, or little of amounts, small amounts. So you get where you have trouble urinating. Prostate cancer is the second most common cause of cancer deaths in males. We can screen by looking at prostate specific antigens, but then afterwards you'll have more testing involved. We can remove the prostate surrounding the urethra, or radiation, or both. It's treatment. Testicular cancer, pretty low rate, 1 in 263 males per year. Most is going to happen because of abnormal spermatocytes or spermatogonia, so stem cells, or during meiosis. So it's going to be issues with either happening with mitosis or meiosis. So treatment is an orchiectomy, which is castration or testes removed, and chemo, but there's a large survival rate because usually it can be diagnosed pretty early because you can kind of feel and see testicles. We also have improved treatment as well. We see issues in breasts. So changing in levels of the hormone can actually change inflammatory issues in the mammary glands. We can have cysts if there's inflammation in those lobules, and then there's scar tissue around it. So remember, kind of have all the lobules, and then we have a lobule kind of walled off by scar tissue. Then we can have a cyst form. There's also fibrocystic disease where you have a bunch of cysts and they actually are felt like masses, but they're cysts. They're not actual tumors. But sometimes we need biopsy to see, even with imaging like a mammogram, a cyst, many cysts can look like a mass. So it may need biopsy to make sure that it's a cyst and not breast cancer. Breast cancer is malignant and oftentimes it can spread, and it can spread to lymph nodes first. Uh, Leading cause of death in women 35 to 45, and most, at least with cancer, and most common after 50. We have found that there's a family history increases the risk, like the BRCA gene is going to significantly increase the risk of developing breast cancer. Late pregnancy after the age of 30, and early menarche, which is your first period, or late menopause. So you're exposed to hormone changes a lot more if you have an earlier period or a late stopping to menstruation. Treatment, surgery, radiation, chemo, sometimes hormones, surgical removal, either the entire gland or partial. So you can have a lumpectomy, which is just a lump, or you can have a mastectomy, which is the entire gland. Sometimes it even needs the lymph nodes in the armpits. So you can just look at this is looking at breast cancer. Ovarian cancer is very severe, more deaths than any other cancers of the female reproductive system. Chemo, radiation, and surgeries, treatment, so kind of a lot of the cancers. If we have cancer that starts in the ovarian tissues or abnormal oocytes, then it's a better prognosis. So this is going to be more where the follicles are in the cortex. If you have a carcinoma, which is going to be of the epithelial layer or the outer layer, 85% of cancers are actually carcinomas, and that's the worst prognosis, unfortunately. So looking at ovarian carcinoma, severe enlargement of the ovary, taking cancer tissue, taking over the ovary versus a normal one. Cervical cancer, so cancerous tissue starts in the cervix. We do have a decreased death rate because this can be found on pap smear, so early detection. And we also have a vaccine against HPV, which is going to lead to a lot of cervical cancers. So we're getting more preventative with cervical cancer, so a lot less severity.